Good morning, everyone, and this revision of Neonatology Part 3 for MRCPCH Part 1. Question number 1. 3-week-old infant came to emergency department, has recently problem completing his feeds, and today appear tachypnic. On examination, hepatomegaly 4 cm. All blood tests are normal. What is the most common? What is the most likely diagnosis? Is it congenital toxoplasmosis, delayed GPS, galactosemia, meningitis, or cardiac failure? So, 3 weeks old, hepatomegaly, tachypnia. Congenital toxoplasmosis is wrong because it usually comes with hepatosplenomegaly and lymphadenopathy, and there is anemia and thrombocytopenia. Delayed GPS infection is wrong because all blood tests are normal. Galactosemia also is wrong because there is no hypoglycemia. Meningitis also wrong because all blood test is normal. So this typical presentation of cardiac failure. So the correct answer here is cardiac failure. Second question, 6 weeks old, came to emergency department. His parent complaining that he is always crying. On examination, he is febrile but irritable and has bulging fontanelle. Urgent CT showed multiple hemorrhage and generalized edema. What is the most likely diagnosis? Is it meningitis, Wilson disease, galactosemia, or non-accidental injury? This is the most common presentation of non-accidental injury. The baby is crying, examination is normal apart from irritability and bulging fontanelle. We do CT scan, we found multiple hemorrhage and generalized edema. So the correct answer here is non-accidental hemorrhage, non-accidental injury. A girl was born at 25 weeks. She is now 37 weeks corrected gestational age. Is due to discharge from an ICU and home oxygen. She was intubated at birth and ventilated for 4 weeks. Which of the following is most likely contributed to the development of PPD? Prolonged ventilation, low ventilation pressure, hypoxia, caffeine, or female sex. So the most common cause of bronchopulmonary dysplasia is prolonged ventilation because it leads to barotrauma of the lung and alveoli will be not healthy and the baby will need oxygen for quite long time. Caffeine improves the respiratory drive. Hypoxia can lead to respiratory distress but not to bronchopulmonary dysplasia. Low ventilation pressure actually it improves the outcome of bronchopulmonary dysplasia. Female sex is not contributed to it. So the correct answer here is prolonged ventilation, which is the main cause of bronchopulmonary dysplasia. Question number 4. The community midwife completes the day 5 Haleberg blood test in a newborn baby. Which one is excluded from the Haleberg test? Phenylketonuria, isovaleric acidemia, sickle cell disease, jaundice, or cystic fibrosis. So there is quite amount of tests we do in day 5. In UK, we do here 9 to exclude it, 6 metabolic disease and 3 blood and sickle cell disease, cystic fibrosis, congenital hypothyroidism, and the metabolic disease is homocystinuria, phenylketonuria, marble syrup urine, and other 2 or 3. So, which one is excluded here is jaundice. So, jaundice is not a part from day 5 Haleberg test. Question number 5. Early signs of kernicterus are noted after day 4 of life. The earliest clinical manifestation is fever, lethargy, bulging fontanelle, obstinatosis, butchering, paralysis of upward gaze. The correct answer here is lethargy. So, the correct answer is lethargy, which is the earliest clinical manifestation. Question number 6. Which of the following sequel of kernicterus is resolved in surviving infant? Spasticity, nerve deafness, chloroacetosis, enamel dysplasia, discoloration of the teeth. So the correct answer here is spasticity, which resolved completely in surviving infant. Other sign CP, nerve deafness, enamel dysplasia, and discoloration of teeth is a permanent sign. Question number 7. All the following are risk factor for polycythemia except trisomy 13, prematurity, neonatal hyperthyroidism, infant of diabetic mother, IUGR. Which one of these? Polycythemia definition as hematocrit more than 65%. In IUGR, yes, there is polycythemia. And in infant of diabetic mother, yes, there is polycythemia. In neonatal hyperthyroidism as well. In trisomies as well, there is polycythemia. But in prematurity, usually there is anemia. So the correct answer here is anemia. So the correct answer here is prematurity, which comes with anemia. Question number 8. Chest X-ray of PPHN usually reveals hyperinflation, normal lung field, small pleural effusion, bilateral lung infiltration, prominent vascular marking. In PPHN, it's not hyperinflated, and there is no effusion. There is no infiltration. there is no increase in bronchovascular marking. So, usually the chest X-ray of PPH and PB is normal lung field. So, the correct answer here is normal lung field. All the, all the following are clinical manifestation of bronchopulmonary dysplasia except poor growth, oxygen dependence, right side heart failure, pulmonary hypertension, compensatory metabolic acidosis. So, yes, there is poor growth. Yes, they are oxygen dependent. Yes, that right side heart failure. And there is pulmonary hypertension. Compensatory metabolic alkalosis and not acidosis. So the correct answer here is compensatory metabolic acidosis, which is wrong. Usually it comes with compensatory metabolic alkalosis. So the correct answer here is E, compensatory metabolic acidosis, which is wrong because it comes with hypercapnia and compensatory metabolic alkalosis. This was the last question, and I will stop neonatology revision here, and I will start nephrology revision next video. Thank you.